leading a new initiative called Geriatric Transitions Consultation and Comprehensive Care. We can talk about that now. Thank you.
I'm going to try not to stay behind the podium because I don't do well behind the podium. I was invited to talk about GeriTrack, although the component of GeriTrack which I was invited to talk about, some people would argue isn't really primary care. But I'll say that my vision of GeriTrack and how it extends into what I plan to do down the stream, and if you invite me back in a year, I'll tell you about my other plans with working with the Institute on Aging, is really to, in very much the way Mia says, to change medicine and the care for older people, because there has to be a better way. And for those of you who are out there working or learning, whenever you think there has to be a better way, that's sort of the flag for you. And when I went through my fellowship and then subsequently working in the communities for 3 years, I was constantly coming up with this in my mind: there has to be a better way, there has to be a better way. Talking to my colleagues who are here at UC, and hearing about the care that our oldest, frailest patients were getting, and I just thought, there has to be a better way to care for our oldest, frailest patients. So I'm really going to use this opportunity to think about how we can redefine continuity of care, which is usually what we think of in terms of primary care. They're going to be describing sort of how that has changed over time. So if we think about sort of then and now, there's kind of the classic picture of physicians, which we already know about. The physician who sees their patients in clinic, admits them into the hospital locally, and then follows them when they come out, and takes care of them in the home until their patient dies. And this is a very, very rare model now. So what we're actually faced with now is the patient, which I'm going to describe for you, someone who I see in the GeriTrack Transitional Care Service, which is by no means one of our sickest patients or one of our frailest patients. I would say she's sort of average, but she's our sort of typical 70-year-old woman with all of your standard chronic illnesses that we always see, and those are just her illnesses. I will say functionally she has extreme difficulty mobilizing around her house. She can't get down her stairs, and almost every house in San Francisco has stairs, and she's got some trouble with cognitive impairment. She does have actually a pretty good support system, and she's got a very loving husband. Now, she is one of our patients who has been admitted to UCSF 8 times in 10 months. And not for very long, but for about 37 hospital days. Now, how many guesses as to the number of providers she has seen in the 8 admissions she's had over 37 days? How many? 60. 64. Any other guesses?
42.
42. 100? Who said 100? So I think this is an underestimate. There were 51 inpatient providers and consultants. So I went through UCare and I counted out how many signed, different signatures there were. This does not include necessarily all the student contacts, the Jeopardy resident, the cross-cover night float. So these are just the folks who signed notes on this woman. Now, I thought, well, surely in the realm of social services, there were fewer social workers, because we know there aren't that many social workers in the hospital, and maybe there's some more continuity there. And I was quite surprised. There were 8 social workers who saw her over the course of these 8 admissions. And now this woman is actually cared for by one of UC's really well-regarded primary care physicians. And she actually has seen her primary care clinic 8 times over these 10 months, which is probably more than many primary care patients get, especially someone as sick as she is. Now, when you look at the signing physician, 4 of those visits were with a covering physician, and this is sort of the reality we face in an academic medical center. So how do we make this better? So what we're faced with here is that a subset of our patients, those who are frail and have significant debility, are at high risk for readmissions. And when I say high risk, I'm talking about all kinds of factors, but things, for example, such as cognitive issues, literacy issues, medication misadventures, whether from transcribing or prescribing, or insurance difficulty getting issues. And all these patients meaning they are closer to the end of their life than they are to the beginning. And we may be talking about years, but we may be talking about months, weeks, or days. So there have been several models of care that have been designed over the last few plus more years to try to address these issues. And these are catchphrases that you've probably heard. So transitional care. People have maybe heard about the BOOST project here at UCSF. Transitional care is kind of a hot topic. It's all about how do we care for patients as they transition across sites, so from the hospital, from the nursing home. I would say most of the time when transitional care is used, it's generally talking about the hospital to home or SNF transition, but it really needs to account for everything. Patient-centered medical home, which Nat kind of threw out earlier. And technically this is all about centralized patient care, patient-centered focus with case management, care coordination that follows patients across their trajectory. And then I'm putting up palliative care because for our frailest, our sickest, our most debilitated patients, these are the patients who really we need to be getting palliative care involved, because it doesn't matter if you have a good transitional care, if we haven't talked about end-of-life issues, it doesn't really help. So the GeriTrack service is a service which, I'll be frank, has been morphing over time. It's 10 months old. We started this with the goal that we would provide home-based post-discharge transitional care visits to patients from a physician perspective. And over time, it's changed a lot in many ways. So we not only see patients at home after the hospital, we see patients in the hospital when they're here at UCSF, and we see them in a couple of the nursing homes in San Francisco, as well as they transition into hospice, if that's the direction that they've gone. And our role is not to replace the primary care provider. So part of my hat that I wear clinically is I'm a primary care provider too, and I really value that relationship that people have. So we're not there to replace primary care providers. We work sort of in collaboration with them, the inpatient teams, the SNFs, the home care, and the hospice agencies. We provide geriatrics consults to sort of pay specific attention to cognitive capacity, literacy issues, what their function is, polypharmacy, kind of understanding what the caregiver and support structure is, and then also providing palliative care consults not only in the hospital, but as they transition out for end-of-life issues, and really to focus on the big picture. Sort of, as we found, what we've been able to provide for some of these sickest patients is some semblance of a constant, which again is not meant to replace their primary care physician, but to work with the primary care physician and the inpatient teams so that the level of contact and communication and care has some continuity, true continuity, across their multiple hospitalizations. So this is the challenge to you. This is the reality we have. We have very sick patients. Some of them may be in the hospital far more than they ever are out of the hospital, and I include SNF in that. The reality is that most primary care physicians are rarely able to see their patients in the hospital or SNFs, even if they want to. And some may make home visits, but many are not able to. Some patients, frankly, become homebound. And then even the best coordinated care for sick patients who have multiple hospitalizations may still not be the best care possible for them. So I want to kind of pose to you the idea of redefining continuity of care, and really think about true continuity beyond just transitions of care or care coordination, really thinking about continuity of care and what does that mean, and how might we actually be able to provide for this in this day and age with the healthcare workforce and financing structure that we have. I don't have all the answers to all of this, but sometimes bridging and patching between care is not always the best way. We need to think about how can we travel where the patient goes. Who is the appropriate patient for this kind of service? And accessibility. For some patients, a phone call to the clinic to get the operator who gets paged to the outpatient provider who then calls back to the patient an hour later, that might work well for some patients, but for patients who are very frail, who perhaps aren't on hospice, sometimes that's too long. They're already in the ED at that point. So the way I think about GeriTrack and ways that we can think about services such as this is, can we be an extender for primary care physicians, or in some ways a connector to take all of the different subspecialists, the inpatient providers, the primary care physician, the home care agency, and connect them so that all the communication is actually on the same page. To think about looking at the forest, sort sort of the big picture of the palliative care focus as well as the trees. So what are the medication side effects that someone's dealing with? Is the fact that we sent the patient home with a scale, is that good? Well, if the patient can't stand on their own, well, there's no use that scale will provide them. So it's kind of looking at all of those things. And then this is just something, it's a thought I've had in my mind for a very long time. And we think about consultants as specialists that we seek help from in the hospital or outpatient, who can help us, the primary care physicians, make decisions about things or make movement on a care plan. Sort of the thing I've had constantly in my mind is, what about the outpatient primary care provider as the inpatient consultant? And how many times do we have patients that we see in the inpatient setting who have consultants from cardiology, from nephrology, from pulmonary? And really, if we could just bring that primary care provider in to see that patient and talk to the team and talk to the specialist, maybe we wouldn't need all those consults, and maybe we would be able to move the patient in the direction that they actually want to go.